Hello and welcome in the revision program for Orthopedics for FMGE examination 2022, a December session. Without wasting any time further, let's have a sample question. The first one is the Klumpke's palsy. That not a feature of Klumpke palsy. Now all of you know that Klumpke palsy is the compression of lower trunk of the brachial plexus, which is made up of C8 and T1. So extension at the metacarpophalangeal joint, one of the feature of Klumpke palsy is a claw hand. And in claw hand, there will be a hyperextension of the metacarpophalangeal joint. So this is the correct answer. Next, mydriasis. One of the feature of Klumpke palsy is a Horner syndrome because of the compression or because of the injury to the T1 root, which is supplying a sympathetic function to the eye. And the sympathetic function to the eye, if it gets injured, it will lead to meiosis, not mydriasis. Alright, so mydriasis is not a feature for Klumpke's palsy. Loss of ciliospinal reflex, which is again a component of the Horner syndrome, which are meiosis, then loss of ciliospinal reflex, then ptosis and hydrosis. Alright, and ophthalmos, all these are the features of the Horner syndrome, which are the functions or the features of Klumpke palsy. And finally, there will be a thoracic outlet syndrome. Actually, thoracic outlet syndrome is considered to be the etiology for the Klumpke's palsy, because in thoracic outlet syndrome, there will be a compression of the lower trunk of the brachial plexus, and lower trunk of the brachial plexus injury in turn is known as Klumpke palsy. So thoracic outlet syndrome will lead to all the features of Klumpke palsy. Alright, so hopefully you get the correct answer for this particular question. That is mydriasis. That means dilatation of the pupil is not a feature of Klumpke's palsy. That means compression of lower trunk of the brachial plexus. Next, about this very commonly asked topic, ankylosing spondylitis, which one is incorrect? Point number 1, uveitis is common. As far as extra articular manifestations of ankylosing spondylitis are concerned, it is uveitis, then cataract and glaucoma. And acute anterior uveitis is considered to be the most common non-bony feature of ankylosing spondylitis. So this option is true. Second one, dilated cardiomyopathy can occur. You see, two features related to cardiac anomaly in case of ankylosing spondylitis are aortic valvular disease, that means aortic valvular insufficiency, and degrees of heart block, that means third degree of heart block. Alright, dilated cardiomyopathy is not a feature of ankylosing spondylitis. Then the third one is pain in sacroiliac joint is important in establishing the diagnosis. You just try to understand this, that if a patient is not having a pain in sacroiliac joint, you can rule out ankylosing spondylitis, because it is not only considered to be the earliest clinical finding, but the most consistent clinical finding in case of ankylosing spondylitis. Alright, so pain in sacroiliac joint is extremely important in establishing the diagnosis for this particular condition. So this option is also true. And finally, young males are more commonly affected. 15 to 25 years of age, the males in particular are affected by this condition, that is ankylosing spondylitis. So if you read out the question, then you will find that dilated cardiomyopathy is not the correct answer. As far as cardiac manifestations are concerned, these are aortic valvular disease or aortic valvular insufficiency and the third degree heart block. As far as the X-ray findings of ankylosing spondylitis, how will you identify the X-rays? These are the vertebral bodies and this is intervertebral discs. When intervertebral discs are also calcified, so that the entire vertebral body or entire vertebral column seems to be in a continuity without any break in the form of a soft tissue, then it will be appearing like a bamboo. Alright, bamboo spine. So that means the bone in continuity, because the soft tissue structures like intervertebral disc will also get calcified. Then the second one is the dagger sign. Now what is dagger sign? It is the calcification of the interspinous ligament, which make this appearance to mimic like a dagger. Alright, so this is the reason why it is called by the name of dagger sign. Ankylosing spondylitis related X-rays identification is that there will be no reduction in the disc space, there will be no displacement of the vertebral bodies. Only thing which is happening is the continuity of the vertebrae in the form of a bony structure. The intervertebral discs are also calcified, so it appears like a bone in continuity. Alright, next, nerve injury with intact outer nerve sheath. Now all of you know that nerve injury classification is Seddon's classification. And Seddon has classified the nerve injuries into three types. One is neuropraxia, other one is axonotmesis, and the third one is neurotmesis. Now in neuropraxia, what is happening? That there is no anatomical disintegrity in the nerve. It is only that the nerve is not behaving normally. The nerve is not functioning normally. there will be a block in the conduction of the nerve impulses. In case of axonotmesis, what is happening? The outermost layer of the nerve, that is epineurium, it remains intact. Well, inside, any of this structure could be injured. Like there could be injury to the axon, there could be injury to the fascicle, there could be injury to the perineurium, there could be injury to the endoneurium. So any of this structure could be injured inside the nerve, but the outermost sheath, that means epineurium, it remains intact. While in case of neurotmesis, what is happening? That there is a complete injury to the nerve. That means epineurium is also injured. So out of these three, worst prognostic outcome is going to be there in case of neurotmetic injury. Best prognostic outcome is going to be there in case of neuropraxia, because neuropraxia is a transient kind of nerve injury. And you already are aware of the neuropraxic injuries in the form of Saturday night palsy, the tourniquet palsy, which are transient or temporary kind of nerve injuries. All right. So which of the following is the correct answer, where the question is asked for that nerve injury with intact outer nerve sheath is axonotmetic injury. The outer nerve sheath, that means epineurium. All right. Now name the nerve being tested. If you look at the image, here you are testing the adduction of the fingers by placement of a card in between. As an examiner, you are trying to pull this card out, asking the patient to hold the card in between the fingers firmly. If the patient is not able to hold the card, and if the patient is, you can easily pull this card out, that means card test is positive. So which of the following is the nerve being tested by asking a patient to perform a card test? It is ulnar nerve. Alright, so hopefully you already are aware of the answer for this particular question. Now, based on these sample questions, like card test, we have discussed that adduction of the finger is being tested. That means palmar interossea is being tested and ulnar nerve is being tested. Alright, so card test is a test for the ulnar nerve. Similarly, book test. When you ask a patient to hold the book in between the thumb and the rest of the hand, that means you are asking a patient to hold the book by adduction of the thumb. You are testing the ulnar nerve. If the patient is able to apply resistance, ulnar nerve is functional. If you can easily pull this book out, that means ulnar nerve is not functional. That means adduction of the thumb is weak. It is again for the ulnar nerve injury. The book test. The card test is also for ulnar nerve injury. Similarly, another test is Froment sign. Now what is happening is that when you ask a patient to hold the book tightly in between the thumb and the fingers, but if he is not able to apply resistance, then he will try to flex the interphalangeal joint of the thumb. When the patient is asked to hold it tightly or apply resistance, then he is applying resistance by bringing the flexion at the interphalangeal joint of the thumb. Alright, so he is modifying the book test into something else, and that something else is known as Froment sign. So Froment sign is again a modification of the book test, and the name of the nerve for which this test comes out to be positive is ulnar nerve test. Pointing index. Now all of you are aware of the fact that flexor pollicis, flexor digitorum superficialis as well as flexor digitorum profundus, the two tendons of the index finger, are solely supplied by the median nerve. Rest we are having an overlapping supply by the ulnar on the medial side. So when you are asking a patient to form the fist, and in case the median nerve is injured, then one finger remain extended. That means one finger will be pointing towards you. The name of the finger that remains pointing towards you is a index finger. So pointing index is a feature of a median nerve injury. Similarly, ape thumb deformity, because of the unopposed action of the adductor pollicis, when all the other muscles which are supplied by the median nerve in the thenar eminence gets paralyzed, it will result in an ape thumb deformity, which is again a feature of a median nerve injury. Then pen test, when you ask a patient to touch the pen by abducting the thumb or by bringing the abduction into action, it is again the abduction of the thumb being tested or being supplied by a median nerve, so it is a test for median nerve injury. So pen test is again a test for median nerve injury. And finally, the claw hand. Now all of you are aware lumbricals are responsible for extension at the metacarpophalangeal joint and flexion at the metacarpophalangeal joint, and if the lumbricals are getting inactivated because of median as well as ulnar nerve injury, so it will lead to a complete claw. So this claw hand is because of both median as well as ulnar nerve injury. And in case of a partial claw, what happens when there is a ulnar nerve injury, it will result in a claw deformity of the medial two fingers. All right, so at least one question is going to be asked based on the anatomical perspective as well as or in the form of a one-liner out of the topics that we have discussed. Next, which of the following is the commonest type of tuberculosis of the spine? This question is already you are aware of this, and the answer for this question is paradiscal. Paradiscal means where there is a primary involvement of the intervertebral disc and the adjacent vertebral body. So paradiscal involvement is the commonest type. The least common type is the posterior type. where anything could be affected, like lamina, pedicles, the spinous process, transverse process, or the articular facets. As far as central type is concerned, there is a primary initial involvement of the vertebral body, and then it might progress to involve all the other structures around the vertebral column. But the primary initial involvement was there in the vertebral body. So that is central type. It is second most common type. And the third one is the anterior type, where there is a prevertebral abscess formation. All right. So most common type of tuberculosis of spine is paradiscal type. Least common type is posterior or appendiceal type. And out of these multiple structures which could be affected in this appendiceal type, the facets are least commonly affected. All right. Next, if you are asked to identify the X-ray of a tuberculosis of a spine, then what are two things that you have to focus on is the reduction in disc space. All right. There will be always a reduction in the disc space. And second, there will be adjacent vertebral body destruction. So there will be a destruction of the end plates of the vertebrae, and there will be a destruction of the intervertebral disc space. When these two things are present in your X-ray, probably they are asking a question related to tuberculosis of the spine or the Pott's spine. All right. Next question is pertaining to osteonecrosis head of the femur. Which of the following is incorrect? Actually, this entire topic is being converted into a form of the questions, where we are going to discuss each and every option in the form of the topic in particular. So osteonecrosis head of the femur, first of all, you have to understand what exactly is osteonecrosis. Like if this is the head of the femur, neck of femur, greater and the lesser trochanter. Osteonecrosis head of the femur is represented by avascular necrosis. That means there is avascularity of the head of the femur, which is bearing weight of the individual. All right. So it will be having its consequences. Alcoholism is a cause. As far as causes are concerned, you can divide it into two. One is traumatic, other one is non-traumatic. Traumatic causes like fracture neck of femur, dislocation of hip, fracture acetabulum. All of these can result in avascular necrosis, secondary avascular necrosis head of the femur. On the other hand, there are several non-traumatic causes like alcoholism, smoking, steroids, antiretroviral drugs, like some of the metabolic disorders like Gaucher disease, sickle cell anemia, or like Kaizen disease. So these are the conditions which can result in avascular necrosis head of the femur, which are non-traumatic. And out of these non-traumatic conditions, alcoholism is considered to be a very common clinical entity, a very common clinical cause identified to cause the osteonecrosis head of the femur. All right. Next, limitation of abduction and internal rotation is considered to be a diagnostic clinical finding for osteonecrosis head of the femur. It is considered to be most specific clinical finding. Most specific sign for osteonecrosis head of the femur is the limitation in the range of abduction and internal rotation for that particular hip. Next, reduction of the joint space is the early X-ray finding. Actually, reduction of the joint space is the last X-ray finding in case of avascular necrosis head of the femur. Now, if you look at the X-ray findings for, like what are the early X-ray findings for avascular necrosis head of the femur? It is going to be one, sclerosis in the head of femur. There will be increased density. There will be sclerosis because of the necrotic calcification. This area appears sclerosed. All right. It will be appearing more dense in comparison to the normal. So that is one. Point number two, because this area of the head of the femur will become weak under the influence of the weight bearing forces, there will be appearance of the subchondral fractures. So this subchondral fracture is known as crescent sign. So these are the earlier X-ray signs for X-ray of the avascular necrosis head of the femur. Then because of the appearance of this subchondral fractures, it will result in the flattening of the head of the femur. Means head of the femur will become flat over a period of time. It will lose its sphericity. There will be flattening under the influence of the weight of the patient. All right. The head of the femur is now weak, is not able to bear weight of the individual, is getting flattened over a period of time. So these are considered to be the earlier X-ray findings. Reduction in the joint space is suggestive of secondary osteoarthritis, which is considered to be the last X-ray finding for avian head of the femur. Now, this is the kind of the X-ray finding which is provided to you so that you can compare it with the tuberculosis of the hip. In case of tuberculosis of the hip, the earlier X-ray finding is reduction in the joint space, while in this case, it is considered to be the last X-ray finding. And finally, what are the names of the drugs which are helpful in the management of avian? One thing is that these are not the drugs which can cure the condition. These are the drugs which can just limit the progression of the condition, and that too in the earlier stages, that too in the pre-collapse stage of the osteonecrosis head of the femur. The drugs which are helpful are the bisphosphonate, that is alendronate, then the lipid lowering agents like statins, all right, and anticoagulants like enoxaparin. So these are the drugs which can limit the progression of the condition. They cannot cure the condition. They will limit the progression of the condition, and that too in the earlier stages of avascular necrosis head. That too in the pre-collapse stages of avascular necrosis head of the femur. All right. Hopefully you get the answer for this question, which is obvious that X-rays in the earlier stages are going to demonstrate sclerosis. They will be demonstrating the crescent sign. There will be a flattening of the head of the femur, as you can very clearly see in this particular X-ray, that this is the normal side. Here this is the spherical head of the femur, and here there is a flattening of the head of the femur on the abnormal side. Then there is multiple sclerotic lesions in the head of the femur, where there is no normal density of the head of the femur is lost. But at this stage also, the joint space is clearly visible. All right, you can appreciate this joint space. So joint space reduction is the last X-ray finding for avascular necrosis head of the femur. Next question is dequervant tenosynovitis. Now, it is a clinical condition where there is a compression of two tendons within the first compartment of the extensor retinaculum, and the name of the two compartments are abductor pollicis longus and extensor pollicis brevis. All right. The name of the test for diagnosing this condition, already you are aware of this, is the Finkelstein test. All right. And what are the clinical features for this particular condition? The condition is extremely painful, particularly at rest, and there will be a tenderness over the styloid process of the radial end. All right. And Finkelstein test is when you ask a patient to form the fist and forcefully ulnarly deviate the wrist, then the condition will be exceedingly painful for the patient. So this is what the Finkelstein test. So name of the two tendons which are getting compressed in this dequervant tenosynovitis are abductor pollicis longus and extensor pollicis brevis. All right. Next question is related to osteoporosis. Again, the entire topic is being divided into 4 topics and into 4 options, and which one is found to be incorrect, they are asking about. So osteoporosis, which of the following is incorrect? Like normal alkaline phosphatase, normal calcium. Now, osteoporosis is considered to be a condition which is a primary decrease in the bone mineral density of the bone related to age. All right. So it is not a metabolic abnormality where there will be increase in the alkaline phosphatase. It is not a kind of a deficiency there where there will be a decrease in the calcium level concentrations. All right. So calcium level concentration in the blood as well as alkaline phosphatase are found to be normal. This is true. Low backache is considered to be the commonest clinical finding. You see what happens when the patient is osteoporotic, and if there is an appearance of the collapse in the vertebral body, when multiple of the vertebral bodies start collapsing without any significant trauma, it is considered to be the most common cause for pain in a patient who is suffering from osteoporosis. All right. So chronic low backache is a presenting feature of a patient who is coming with osteoporotic abnormality. Then is it diagnosed by Z-score? Osteoporosis is diagnosed by T-score. It is the secondary osteoporosis which is diagnosed by Z-score. We had a discussion on this, and we have discussed it thoroughly in our lectures, that how Z-score is different from T-score and what is the essence of this Z-score, what is the reason why Z-score is being implemented, so that you can identify that who is the person who is suffering from primary senile osteoporosis and who is the person who is suffering from any secondary osteoporosis. That means there is a pre-existing cause which is leading to this osteoporosis. All right. So for that secondary osteoporosis, Z-score is required. Next, bisphosphonates. Yes, no doubt that bisphosphonate is considered to be the first line drugs in the management of osteoporosis, be it primary or in majority of the cases secondary. All right. So for this particular question, one option which is ruled out as far as the other options are concerned is the diagnosis by Z-score. Primary osteoporosis or simple osteoporosis is diagnosed by T-score. Secondary osteoporosis is diagnosed by Z-score. Next, What is the diagnosis for this particular condition? They have given you the X-ray, and now they are asking about the diagnosis. Now, if you look at the X-ray, first of all, you have to identify that it is the X-ray of the LS spine. That means lumbosacral spine, and that too a lateral view. So it is the lateral view. So in the lateral view, what you can very clearly observe is that these are the vertebral bodies which are inclined in a single linear column, but one of the vertebral body is posteriorly displaced. And that posterior displacement of the vertebral body is listhesis. It is a spondylolisthesis. Spond is the word which is used for axial skeleton. Listhesis is the displacement. So it is a spondylolisthesis. That is the correct answer for this particular question. Now, if you want to rule out that what are the other options which are provided to you, like renal osteodystrophy. What happens in case of renal osteodystrophy? We get the X-rays in the form of a rugged jersey spine. There will be alternate bands of the increased density of the vertebral end plates. In case of achondroplasia, there will be a bullet vertebrae. The bullet-shaped vertebrae or the bird beak appearance of the vertebrae will be there. There will be anterior beaking of the vertebrae. In case of Paget disease, what happens? There will be a picture frame vertebrae where there will be outer columns will be more dense in comparison to the central core. So picture frame vertebrae is going to be the X-ray appearance for that. Here, in case of listhesis, it is very clearly evident that at the level of L4 and L5, L5 is posteriorly displaced, leading to the condition called by the name of spondylolisthesis. All of you are aware of the fact that spondylolisthesis is the break in the pars interarticularis. All right. Now, TB hip stage of early arthritis, which of the following is incorrect? Now, all of you know that tuberculosis of the hip joint is being categorized into 4 stages. Stage 1 is the stage of synovitis. Stage 2 is the stage of early arthritis. The stage 3 is the stage of late arthritis, while the stage 4 is the stage of dislocation. All right. So these are the 4 stages. Now, in stage 1, that is a stage of synovitis, the hip joint or the thigh, it attains the attitude of flexion, abduction, and external rotation. And all of you, means in a lecture we have discussed how it is responsible for bringing it into flexion, abduction, external rotation. And there will be apparent lengthening of the limb. This also, the reason for this apparent lengthening also we have discussed. While in case of early arthritis stage, what happens is that there will be flexion, adduction, and internal rotation, and there will be apparent shortening of the limb. It is not a true shortening, only the apparent shortening, which will be appearing as if the length of the affected limb appears to be shorter in comparison to the normal. Then, in case of late arthritis, what is happening? There will be flexion, adduction, internal rotation of increased severity. That means attitude will remain the same, but the degree of severity will be increased. And in this case, patient is going to witness a true shortening. On examination, you will identify that there is a true shortening happening on the affected limb. While finally, there will be a stage of dislocation. So these are the 4 stages in tuberculosis of the hip joint. Now, as far as the sample question is concerned, they are asking that TB hip, a stage of early arthritis, which of the following is incorrect? Now, reduction of the joint space, obviously, because once the synovitis stage has been converted into early arthritic stage, there will be a reduction in the joint space. Arthritis means there will be an involvement of the joint, there will be destruction of the joint. All right. So there will be reduction in the joint space. Next, adduction, internal rotation of the hip or the thigh. Yes, it is happening in case of early arthritis. Apparent lengthening of the affected limb is a feature of synovitis. Apparent shortening is a feature of early arthritis. And finally, pain more at night. Carries this night cry. Night cries are the features of early stages of the tuberculosis of the hip joint, because the spasm around the hip joint muscles is relieved at rest. So it will bring about the small frictional movement at the level of the hip joint. Thereby, exposed nerve endings will be getting frictionally connected, will be resulting in the pain. The patient is going to feel pain more at night in comparison to the day where the patient is mobile. All right. So that too is the feature of early arthritis, night cries. So hopefully you get the answer for this particular question. For this, you have to go in detail. You have to learn in detail about all the stages of tuberculosis of the hip joint in particular. It is an important question, not to be missed at any because of any reason. Now, if you look at this particular X-ray, this is the abnormal side and this is the normal side. And here we are having the head of the femur and the acetabulum and the clear-cut evident joint space in between the two. But in this case, what is happening? The acetabulum and head of the femur are almost fused. There is limitation of the joint space, reduced joint space, and there is periarticular osteopenia. That means density of the bone around the joint are markedly reduced in comparison to the normal side. So these are the two X-ray findings on the basis of which you will make the diagnosis of tuberculosis of the hip joint. All right. Next question is, what is the name of the nerve? Ulnar nerve entrapment syndrome. Now, out of the different entrapment syndromes which are provided to you in the option, which of the syndrome ulnar nerve is trapped? Carpal tunnel, it is median, which is trapped. Cubital tunnel, it is ulnar, which is trapped posterior to the medial epicondyle of the humerus. Tarsal tunnel, it is posterior tibial nerve, which is trapped. While in case of pronator, it is the median nerve again, which is trapped. So answer for this question is cubital tunnel. You know, there are two entrapment syndromes which are responsible for the compression of the ulnar nerve. One is cubital tunnel and the second one is Guyon canal syndrome. All right. So hopefully this is a straightforward question. You know, just the reason for putting this question, you should be aware of all the entrapment syndromes in the human body. Next, about Rickets, which of the following option is incorrect? All right. Option number 1, low blood calcium, raised alkaline phosphatase. All right. Now, first of all, let's see what are the other options which are provided to you, because in nutritional deficiency ricket, which is the most common variety of rickets, all right, or vitamin D deficiency rickets, the calcium level in the blood comes out to be normal. It is not reduced because it is compensated by parathormone. All right. So let's look at the other options. Prominent abdomen, yes, obviously, because of the decrease in the tone of the resting tone of the muscles in the abdomen or overall in the skeletal muscle, there will be a prominence of the abdomen. Renal failure can result in rickets, yes, because the phosphorus is not going to be adequately excreted. And once there is excessive phosphorus in the human body, it will activate the alternate enzyme in the vitamin D metabolism, and that is 24-hydroxylase, which will lead to the conversion of 25-hydroxylase into, or 25-hydroxycholecalciferol into 24-25-hydroxycholecalciferol, which is less active form of the vitamin D, all right, or inactive form of the vitamin D, physiologically inactive form of the vitamin D. It is of no use, all right. That is point number 1. Point number 2 is that in case of renal failure, alpha-1 hydroxylase is going to be deficient, and you know the alpha-1 hydroxylase enzyme is responsible for converting 25-hydroxycholecalciferol into 1,25-dihydroxycholecalciferol, which is active form of the vitamin D. So this is how renal failure can result in rickets. Protein-rich diet is absolutely helpful because they are responsible for making up the collagen over which the minerals are going to be assimilated. So protein-rich diet is extremely helpful in the management of ricketic deformity or ricketic abnormality. So obviously the option number 1 is incorrect, because in case of the most common type of rickets, that means nutritional deficiency ricket, there will be a normal calcium level in the blood most of the time. So calcium level is found to be normal because it is compensated by parathormone. But there will be raised alkaline phosphatase. Yes, this is true. So overall, for among all the options, this option seems to be incorrect. All right. As far as X-rays are concerned, reading the X-ray is very important. When you get the X-ray of the wrist AP view, probably the examiner is asking about rickets, and the findings you are already aware of. There will be metaphyseal widening, there will be splaying, there will be cupping, there will be fraying of the metaphysis. So many times we have discussed that with meaning, that what is the exact meaning of all these terminologies which you tend to find in order to make the diagnosis of rickets. All right. Next, which of the following is incorrect in relation to the posterior dislocation of the hip? Now, all of you are aware what the posterior dislocation of the hip. Let's talk about the options. Option number 1, sciatic nerve injury. Obviously, when the hip joint is thrusted posteriorly, it is the sciatic nerve which is lying just posterior to the hip joint which might get compressed or injured temporarily. So sciatic nerve injury is the only nerve which could be injured because of the posterior dislocation is sciatic nerve. Next, flexion, adduction, internal rotation of the thigh is considered to be the attitude after getting posteriorly dislocated. This is true that the thigh will be fixed in flexion, adduction and internal rotation. Apparent lengthening of the limb, obviously not, because when it is posteriorly dislocated, the head of the femur is out of the acetabulum and there will be proximal migration. When the head of the femur is proximally migrated, then the length of the entire limb would be shortened in comparison to the normal. So there will be actually shortening of the limb, not the lengthening of the limb. Associated acetabular fracture, just use your common sense. If the head of the femur is getting posteriorly dislocated, one thing, if it has to fracture in order to make way to the posterior dislocation, is the posterior wall of the acetabulum. It will first break the posterior wall of the acetabulum and then it will migrate posteriorly. Alright, so hopefully you get the answer for this particular question. So many times they have asked this question, posterior dislocation and anterior dislocation. Now as you can very clearly see out of these two images, this is posterior dislocation of the hip joint, where the head of the femur is lying posteriorly. Alright, the thigh is adducted, the thigh is internally rotated, and to some extent the thigh is flexed. While in case of anterior dislocation, what is happening, that the thigh is abducted and it is externally rotated. Alright, so it is internal rotation in case of posterior dislocation, there will be external rotation in case of anterior dislocation with abduction. So this is how you can make out the difference in between the two types of dislocations. Next question is about the Colles fracture. Now all of you know that which of the following is incorrect in relation to the Colles fracture. Like malunion is a common complication. All of you are aware that yes, it is a common complication because it is a fracture happening at the corticocancellous junction. So there is an involvement of the cancellous region. Common in elderly, again true that elderly females are more commonly affected. Ventral and lateral displacement, you know, dorsal displacement is considered to be the diagnostic modality. Yes, lateral displacement happens, but to make the diagnosis of Colles, there has to be a dorsal displacement of the distal fragment. So that option is obviously incorrect. And below elbow cast is the management by keeping the cast into palmar flexion and ulnar deviation in order to hold the reduced fragment in its reduced position. Alright. So below elbow cast, Colles cast, also known by the name of handshaking cast, one and the same thing, you already are aware of this. Means Colles cast is something, or Colles fracture is something which we have discussed so many times. The name of the deformity over here is a dinner fork deformity. It is a dorsal displacement of the distal end of the radius where there is an extra articular fracture at the corticocancellous junction managed by a Colles cast, where the wrist is immobilized in palmar flexion and ulnar deviation. Alright. Now, supracondylar fracture of the humerus, which of the following is incorrect? Now, cubitus varus is a common complication. All of you are aware that it will lead to a malunion. This malunion will lead to a cubitus varus or a gun-stroke deformity. So, this option is obviously true. Common in 15 years of age. You know, the most common age group for this is 2 to 5 years of age. Now, it does not mean that a fracture in this region cannot happen in a 15-year-old individual. But in case of old individuals, like beyond 10 years of age, it is not going to be a clear-cut supracondylar fracture. There will be intercondylar extension. The fracture will always, most of the time, will involve the intercondylar junction. So it will become an intra-articular fracture. So in around 15 years of age, the fracture will become intra-articular. It is not going to be pure supracondylar variety. So that is incorrect, obviously. Anterior interosseous is the most commonly injured nerve. All of you are aware. 3 bony point relationship is not affected. You already are aware of this. Because all the fractures around the elbow, the 3 bony point relationship is going to be altered. Be it a lateral epicondylar, medial epicondylar, Olecranon or intercondylar fracture. But in case of supracondylar fracture, 3 bony point relationship is maintained. Now this is what you can very clearly see out of this. That this is a cubitus varus deformity over here. Alright. And this is how it is being managed. You need not to go into the details of the management of supracondylar fracture. Now, next question is scaphoid fracture. Which of the following is incorrect? Now, option number 1, malunion is a common complication. No, it is non-union, which is a far more common complication in case of a scaphoid fracture. And it is due to precarious vascularity, insufficient vascularity. The vascular structure or vascular stature to the scaphoid is insufficient. Alright. Osteonecrosis due to precarious vascularity. Yes, that proximal the fracture, poorer the prognosis in case of a scaphoid fracture. Snuff box tenderness is considered to be a key clinical finding for scaphoid fractures. And X-rays are sometimes not confirmatory. Why you cannot confirm this scaphoid fracture on the X-ray? Because it is often missed. Alright. The patient, you cannot see the fracture in the scaphoid earlier in the course of the X-ray, so it could be missed. The diagnosis is often missed. Alright. So out of the 4 options which are provided, no, it is not the malunion. It is non-union, which is a commoner complication for a scaphoid fracture. Mind you one thing, every time the examiner is going to ask about the scaphoid fracture, he will be keeping a complication in the question. Complication is something that he wants you to know. Non-union and avascular necrosis. That means osteonecrosis. Next, which of the following is the name of the angle? I told you that if the angle constructed around the calcaneum is acute, that means less than 90 degree, then it is Bowler angle. So this is the answer for this question. And if the angle is constructed around the angle, which is around the ankle or around the calcaneum, which is more than 90 degree, that means obtuse angle. It will be a crucial angle of Gissain. So answer for this question is Bowler's angle. Now, which of the following is incorrect for the device which is being pictured over here? First of all, the name of the device is Thomas splint. It is Thomas splint, simple. Now, if which of the following is incorrect? All right. Point number 1, traumatic lower limb immobilization. Yes, in orthopedic emergency, you might have seen this splint where there will be a temporary immobilization of a traumatic lower limb or fractured lower limb. Next, it is an emergency device. Yes, it is kept in the emergency always in orthopedic. Devised by or designed by Hugh Gowan Thomas. This is also true. Before World War II, it was designed by Hugh Gowan Thomas, not for temporary immobilization of the fractures, but for the management, but for the immobilization of the infected knee and hip joints. All right. Straight is the outer bar. You know, if you divide this or if you talk about the parts of this Thomas splint, one is a ring, then we have got the outer bar and the inner bar. Now, what is the difference in between the outer and the inner bar? The inner bar is a straight line, while the outer bar is having a curve or angulation, the proximal angulation at the junction of this bar and the ring. Now, this junction or the angulation is to accommodate the greater trochanter. So, it is the outer bar which is kept lateral when you apply this Thomas splint over to the limb. All right. So, this is incorrect. Because the outer bar is not a straight one. Outer bar is having a proximal angle. That angle is to accommodate the greater trochanter of the femur. Means this is something that you should be knowing about Thomas splint. Now, which of the following is incorrect regarding shoulder dislocation? Point number 1, anterior is common. Actually, out of all the different types of dislocations of the shoulder which can happen, anterior is the most common one. Next, axillary nerve could be injured. What else? If there is a dislocation of the shoulder anterior or posterior, the nerve which is likely to get stretched and injured eventually is the axillary nerve. Then the third one, open reduction and immobilization is a preferred method of management. You see, for shoulder dislocation, you need not to open the dislocation site. You just have to reduce it by closed methods. Either apply Kocher method, Hippocrate method or Stimson's method. So closed reduction and immobilization is considered to be the preferred method. So this is incorrect. Next, adduction internal rotation is the attitude of the arm in posterior dislocation of the shoulder. This is also true. You know, in anterior dislocation, there is abduction external rotation, while in case of posterior dislocation, there will be adduction and internal rotation of the shoulder which happens. So hopefully, it is very clear cut that about or in relation to the shoulder dislocation, which of the following is incorrect. And as far as management for the first time shoulder dislocation is concerned, it always has to be closed reduction and immobilization. All right. Monteggia fracture dislocation, which of the following is incorrect? All of you know what is Monteggia fracture dislocation. It is the fracture of the proximal ulna, yes, with proximal radio ulnar joint subluxation or dislocation. So this is actually the definition of Monteggia fracture dislocation. Posterior interosseous is the most common nerve which could be injured in relation to this Monteggia fracture dislocation. Closed reduction and cast application is never the management. Management is always open reduction, internal fixation. Like if you can see over here, this is a Monteggia fracture. You have to open the fracture site and fix it with the plate or by using the wire in case of a young individual. When you fix the ulna, then the proximal radio ulnar joint will fall back into its original position simultaneously, means subsequently, automatically. All right. So it will fall back into its original position automatically. So this is how open reduction internal fixation is considered to be the management for both Monteggia as well as Galeazzi fractures. All right. You should not manage the Galeazzi fracture because it is having a dislocation. It is having an instability at the respective joint. In case of Galeazzi, what is happening? There is a fracture of the distal radius with distal radio-ulnar joint subluxation. In case of Monteggia, there was a proximal ulna with proximal radio-ulnar joint subluxation. So both of them should be managed by open reduction, internal fixation. All right. So these are the management protocol. Now this is something which we are expecting, that which of the following is not a component of a floating shoulder. You know, if there is a complete fracture of the clavicle and the glenoid, then the entire shoulder assembly is no more connected to the axial skeleton. But in order to call it as a floating shoulder, there is no requirement of proximal humerus to get fractured. Alright, so which of the following is not a component of floating shoulder? So fracture clavicle, yes. Fracture clinoid, yes. Fracture proximal humerus, no, it is not the requirement. And coracoacromial ligament injury means any other soft tissue which is present around the shoulder could be associatedly injured. But in order to call this shoulder as a floating shoulder, there is no requirement of this proximal humerus to get fractured. Hopefully you get the answer for this question in particular. Now, displaced Olecranon fracture, what is the management? You know, all of you are aware that if there is a displaced fracture of the patella, what is the management? It is tension bend wiring. But this time they are not going to ask you about the fractures of the patella. They will be asking about the fractures of the Olecranon. That if the Olecranon is fractured, having a displacement, then how it should be managed. And the options provided to you are closed reduction above elbow slab. Obviously, if there is a displacement, it has to be reduced. All right. Open reduction above elbow slab. So it is not just a slab immobilization, which is adequate for the management of these kind of displaced fractures around the Olecranon. Open reduction and tension bend wiring is considered to be the management. So remember, this time they are not going to ask about patella. They may change the indication of tension bend wiring, and instead of keeping patella in the question, they might give you Olecranon process of the ulna in the question. Now here, there is a displaced Olecranon process of the ulna, which is managed by tension bend wiring. Alright, so this is how it is managed. Now, which of the following is not true related to the CTEV? All of you know congenital talipes, equine, varus. Which of the following is not true? Equinus is the most resistant deformity to get corrected. This is true. Out of the 5 deformities, equinus, forefoot adduction, inversion, then cavum, then internal rotation of the tibia, it is the equinus which is considered to be the most resistant deformity. Then adduction is the most recurrent deformity. This is also true. Like forefoot adduction is the most recurrent deformity. Cavus is corrected first. You know, both in case of Ponseti as well as in case of Kite's method, it is the cavum which is corrected first by putting the foot more into supination. Alright. And finally, DB splint, that means Dennis Brown splint, is used to correct the deformity. No, it is not used to correct the deformity. Never. It is used to prevent the recurrence of the deformity. So it is used for the prevention of recurrence. Alright. This DB splint is never used to correct the deformity. It is used to prevent the recurrence of the deformity. That is the main essence of a DB splint. Next, as far as developmental dysplasia of hip X-rays are concerned, that how will you identify a DDH? You have to draw a horizontal line which is passing through the triradiate cartilage. This line is known as Hilgen-Renner line. Alright. And there are 2 vertical lines which are passing through the outer border of the acetabulum. So these vertical lines are known as Perkin line. So both of them are Perkins line. Now, if you look at individual hip, these 2 lines intersection are creating a quadrant. And on the normal side, the epiphyseal head of the femur is kept in inner lower quadrant, while on the affected side, the epiphyseal head of the femur is kept in the upper outer quadrant. So this is how you will make the diagnosis of DDH on the provided X-ray. There are multiple other questions which can also be asked in relation to DDH, but this is something which is at least required at this level for you to identify about the X-rays. That how will you identify the X-ray? You have to create these 2 lines. One is horizontal, 2 vertical lines, creating a quadrant. Look at the epiphyseal head of the femur placement and mark the answer of DDH. Now, all of you know this is something which we are expecting, that they will give you the image where there will be a asymmetry in the level of scapulae. One of the scapulae is high level, is higher lying scapula. So it is known as Sprengel shoulder, which is incomplete descent of the scapula or a high lying scapula. Alright, Sprengel shoulder. Now, related to the compartment syndrome, which of the following is incorrect? Option number 1, intracompartmental pressure of more than 30 mm of Hg is diagnostic of compartment syndrome. You know, we will talk about this option later. Let's talk about the other options. Pain on passive stretch is the most sensitive clinical feature. You already are aware. If there is a flexor of the forearm under compartment, you stretch the fingers into extension, there will be excruciating pain. So it is considered to be the most sensitive clinical feature. Compartment syndrome is a rare phenomena in open fracture. Obviously, if there is a fracture which is already open, then all these blood which is likely to be collected in case of a limb when the fracture would have been closed, now in an open fracture all these blood is moving out of the bone or out of the limb, so it is not creating a compression to the structures which are present inside. So although it can have poor prognostic outcome, but it is not going to be a compartment syndrome. So compartment syndrome is considered to be a rare phenomena in case of open fractures. Next, presence of skin blebs might not require fasciotomy. This is also true. You see, if there is a presence of a bleb which might appear third day, fourth day or fifth day after compartment syndrome, so it is not the indication of fasciotomy. Now, in majority of the texts, you might have heard that intercompartmental pressure, if it is more than 30 millimeters of Hg, it is diagnostic, you have to go for fasciotomy. It is considered to be the indication for fasciotomy, but actually it is not the correct indication. The correct indication is calculated by the mean arterial pressure. You see, the mean arterial pressure of the patient, all right, and the intracompartmental pressure. The difference in between the two, if it is less than minus 40 millimeters of Hg, the difference in between the two, if it is less than 40 millimeters of Hg, which means that the intracompartmental pressure is getting exceeded all the way up to the mean arterial pressure, or the gap in between the two is getting narrowed, it's being thinned out. This is the correct indication, theoretical indication for performing fasciotomy and making the diagnosis of compartment syndrome. All right. So this is not the correct indication, because you cannot use the universal, or you cannot use the value of 30 millimeters of Hg universally to make the diagnosis of compartment syndrome. Hopefully you get the answer for this particular question. All right. Neuropathic joint disease, which of the following is incorrect? Neuropathic, all of you know that it is because of the loss of pain and proprioceptive sensations that the patient will start having the degenerative joint disease. So which of the following is incorrect? Associated with long-standing diabetes mellitus is considered to be the most common cause. It is considered to be the most common cause for neuropathic joint disease. Second, elbow is the most commonly affected site. No, it is the ankle joint which is the most commonly affected site. Recurrent injury is a contribution. You know, once there is a loss of two protective sensory pathways, one is pain, other one is proprioception, then this ankle or this foot will be subjected to repeated injuries, leading to these degenerative changes in the joint. All right. Appropriate shoe wear is a part of the treatment. You know, appropriate shoe wear is considered very, very important in order to prevent this foot from getting further degenerations in the earlier stages of the management of neuropathic joint disease or Charcot arthropathy. All right. So if you look at this question, you will find that it is not the elbow, rather ankle, the most common site to be affected by this neuropathic joint disease, which is very commonly seen in case of long-standing chronic diabetic patients. All right. Now, in this image, we are just having a pictorial representation of a swan neck deformity and a bottom ear deformity. All of you know what is swan neck deformity, how does it looks like, and a bottom ear deformity. All right. Now, swan neck is something which they have asked multiple of the time. They can ask bottom ear deformity at any point of given time, and it is exactly opposite to what we see in swan neck. In swan neck, there is hyperextension of proximal interphalangeal joint, while in case of bottom ear deformity, there will be a flexion deformity of the proximal interphalangeal joint. This is how both these two things are different. Next, what is the name of the brace over here? Now, first of all, you know, there are two types of braces which are applied to prevent two deformities from developing around the vertebral column. One is scoliotic deformity and the second one is kyphotic deformity. Now, in case of kyphotic deformity, the solid column of the brace is going to be provided posteriorly only. In front, we are going to have the straps. While in case of a brace which is preventing the scoliotic deformity, it will be having a circumferential. It is a circumferential brace. All right. So first of all, just by looking at the brace, you will come to know that it is a circumferential brace which is having both anterior as well as posterior column. So it is a brace which is preventing the scoliotic deformity from further developing. So it is a scoliotic brace. But what is then? Is it a Milwaukee or the Boston brace? Because Milwaukee brace is a CTLS brace where there is a cervicothoracolumbo-sacral immobilization, while Boston brace is a TLS brace where there will be a thoracolumbo-sacral immobilization. Now, if you look at this brace in particular, there is an involvement or there is immobilization of the cervical, thoracic, lumbar as well as sacral. So, answer for this particular question is Milwaukee. Alright. So, if you look at any brace around the vertebral column or in the thoracic or the lumbar region, then you have to identify whether it is a posterior brace or a circumferential brace. If it is a posterior brace with anterior straps only, it is for kyphosis, and for kyphosis we are having talar brace, while if it is circumferentially applied, then it is for scoliosis. For scoliosis we have two types of braces. One is Boston, where there is no immobilization of neck, and the other one is Milwaukee, where there will be immobilization of cervico-thoracolumbo-sacral column of the vertebral body or of the vertebrae. Alright. Next, if you look at this splint, it is keeping the wrist in extension. So any splint which is holding the wrist in extension is known by the name of cock-up splint, and the indication of this cock-up splint already you are aware that it is for the radial nerve injury. All right, holding a limb into extension, holding the wrist in extension is done by a cock-up splint. So whenever you see any splint, any support which is provided to the wrist where the wrist is held in extension, it is cock-up splint. All right. Now, as far as tumors are concerned, every time you see or you attend the questions, you will find a tumor related question which is epiphyseal. Once you confirm it to be an epiphyseal tumor, if the tumor is found to be epiphyseal, you have located it to be epiphyseal, you are left with two options only. One is chondroblastoma, other one is GCT. If the growth plate is still present, that means if the growth plate is still visible in that X-ray, then the answer for this question is chondroblastoma. Simple, because chondroblastoma is a tumor in less than 20 years of age. While if the growth plate is obliterated, that means you cannot see the growth plate in epiphyseal tumor for that particular X-ray, then it is the X-ray of giant cell tumor. Like in this case, this is the epiphyseal tumor, but the growth plate is obliterated. That the patient is skeletally mature. All right. So you go in favor of giant cell tumor. This is how the differential diagnosis of GCTs, that means the epiphyseal tumor, could be made. As far as the malignant tumor X-ray identification is concerned, when you are having a dense core with relatively radiolucent rays, so it is a sunburst or a rising sun or a hair on end kind of the appearance, which is seen in case of osteosarcoma. On the other hand, if you see a diaphyseal kind of a tumor having multiple peel layers around the bone of the periosteum, it is an onion peel appearance of the Ewing sarcoma. Alright, so this is how you will identify the two malignant X-rays, malignant tumor X-rays. One is if there is a growth of the bone outpouching from the metaphyseal end, it is osteochondroma. Straight away, it is going to be a spot diagnostic question. So this is how the osteochondroma looks like. And if they give a picture or the X-ray of the hand where there is a tumor involving a small bone of the hand. Now this is the lytic lesion which is involving the small bone of the hand. That means the base of the the neck of the metacarpal. So it will always be a enchondroma. All right. Now, in case of enchondroma, how will you identify? Because enchondroma is the most common tumor which is involving the small bones on the hand. Enchondroma is a benign tumor. It is a lytic lesion. And finally, if you see a small radiolucent nidus within the long bone cortex, the answer for this question is osteoid osteoma. So this is how you will identify a tumor. And as far as benign tumors are concerned, these are something which is very important, like GCT, chondroblastoma, osteochondroma, osteoid osteoma, and enchondroma. These are the tumors. Malignant tumors are osteosarcoma and Ewing sarcoma. You have to go through them in details. And then finally, yes, this is something which we are expecting, that if there is a imaginary line drawn on the X-ray of the pelvis, including both the hips, imaginary line which is beginning from the inferior border of the superior pubic ramus, extending all the way from up to the medial border of the proximal femur. So normally it is a smooth curve. But if there is a break, that means there is some abnormality in that affected hip. So what is the name of this line? The name of this line is Chanton line. All right. Now another X-ray findings are, clinical findings are a shoemaker line which is involving the tip of the greater trochanter and ASIS. All right. So this line which is joining the tip of the greater trochanter and ASIS is a shoemaker line. So at least for this examination, you have to remember about the shoemaker's line in particular. Both these two questions till date they have not asked in any of the set of the examinations, but yes, we are expecting both these two questions to be kept in your examination in near future. That is shoemaker's line and Shenton's line. Shenton's line on the X-ray, imaginary line, and shoemaker line is a key examination finding line which you have to draw in order to know about the supratrochanteric shortening of the femur. So if they ask this question for the first time, they will be asking about the introductory patterns of these. That a line joining in between ASIS and GT is known as. Answer for that question is shoemaker line. So hopefully it might help you in gaining the answer, in marking the correct answers in the upcoming examination. And by reading the question, you already came to know that what are the important topic that you have to concentrate on. All the best for your examination. Hope you do well.